Welcome back to UC Davis Live. For some people, the symptoms of COVID-19 can last for months and months. These patients are called long haulers, and UC Davis Health recently opened a clinic specifically to help these people. What is long haul COVID? Why do some people have long-lasting health problems, and what can be done to help them? Joining us today are a doctor treating these patients and someone who's experienced long haul COVID. Dr. Christian Sandrock is a professor of pulmonary and critical care medicine at UC Davis Health. He specializes in treating respiratory infections and has been on the front lines of treating COVID-19 patients. Dr. Sandrock is part of the team that recently launched a post-COVID-19 clinic to help patients dealing with long-term health issues associated with COVID-19. And Marina Oshana is a professor emerita with the UC Davis Department of Philosophy and a patient of the UC Davis Health Pulmonary Medicine Clinic. She's been dealing with symptoms of COVID-19 since February of this year. Thank you both for coming on today.
Thank you.
Thanks for having us on.
So before we get started, I just wanted to remind viewers that this is a free webcast. You can watch it live and watch it after the live broadcast on the UC Davis Facebook, Twitter, and YouTube channels. We're aware of others posting links saying that you have to pay to watch this video. Please do not click on those links. This is a free webcast. And we are taking audience questions as usual. So if you're watching us live, just leave them in the comment section. We'll work in as many as we can. So Professor Oshana, I'd like to start with you. Initially, why did you seek out a COVID-19 test all the way back in February, so early in the pandemic?
Well, I actually didn't seek out a test for COVID until the summer. It was in February that I developed a horrible virus that mimicked the symptoms of COVID. So I'm an avid jazzerciser. I love to dance. I was working out 5 or 6 days a week, and I'd largely gotten into that form of exercise because I wanted to keep my lungs healthy. I've got a pre-existing pulmonary condition. So very late in January, I noticed that during the cardio portion of the class, I would get fatigued. I was short of breath. It was very strange because it seemed to come on quite abruptly. And it was a departure from my normal level of energy. The very beginning of February, I developed a wicked sore throat that lasted for about a day. And then for 2 weeks, I was basically prone on our sofa downstairs so I wouldn't keep my husband up at night with a horrific cough, a dry cough that just would not cease. Not productive, just a dry cough, low-grade fever, about 100, 101, so nothing alarming, and exhaustion. So those were the primary symptoms and some shortness of breath, the primary symptoms that I experienced. But because I wasn't doing anything, I didn't, really notice how debilitating this would turn out to be. And I went to see my primary care physician about a week into this because it wasn't going away. And I was given a test for influenza. I'd had a flu shot. I get one every year. I'm very conscientious about that. That came back negative. And the physician said, I just don't know what this is, right? Because it wasn't on anybody's radar, wasn't on the radar of most family practitioners at that point.
Right.
So eventually, the cough went away. I got back to normal, except things were not normal. I remained short of breath and my energy levels had declined. I'd had several COVID tests as they became available to the public over the summer, and they were all negative. But in July, August, I was walking around the block, just walking, just strolling, no jogging. And my chest started to hurt and I couldn't breathe. And I thought, this is not right. There's something wrong here. So I contacted Dr. Sandrock, whose care I've been under for a number of years, and mentioned this to him. And he was concerned and said, I think we need to set up another pulmonary function test for you and, various procedures, maybe a CT scan, I think. And I asked him for an antibody test. I said, I think I had COVID back in March or back in February. And he said, well, he was a bit skeptical because I later learned lots of his patients have said the same thing. And they've all turned out to be negative. Well, mine turned out to be positive. Antibodies did show up. So it was sort of affirming. At least I knew that there was something serious had happened to me. But what has persisted are the some of the symptoms.
Right. So what are some of the symptoms that you've experienced, say over the past few months, now all these months later?
Right. And they have not improved. So definitely my oxygen absorption or saturation rates have gone down. I've been keeping track of, with one of those little pulse oximeters devices that you can pick up at CVS or, so my oxygen absorption is below normal or desirable ranges. That's usually fluctuates, let's say standard between 88 and 92%. If it's a good day and I'm in Davis, I can get up to 97%, which I consider great, not maybe even 98, but as a rule, the oxygen absorption rates have declined. And when I'm working out, because I've continued to work out via Zoom, I definitely cannot keep up the pace. I just get out of breath almost immediately, even when we're doing our warm-up exercises. I feel as if there's a blockage, some sort of obstruction in my chest. I don't start panting, but my breathing, my pulmonary capacity has been compromised, seriously compromised. When I'm in the mountains, my husband and I have a home in Truckee, and we enjoy hiking and doing sort of outdoor activities. Then my oxygen absorption rate or saturation rate, Dr. Sandrock will know the proper terminology for this, but it really plummets. And I had been working out up there as well, and that turned out to be not such a good idea, because I've learned that you can do real damage to yourself. So it looks like hiking is out.
Yeah, and being at the higher elevation doesn't help as well, I would guess.
No, that's the problem.
Right? Yeah. So how are you managing your symptoms right now? What treatments are you receiving?
Well, I'm on an inhaler. I don't know if that's made a difference. It's a Wixella. I think is that how you pronounce it? Twice a day, an aerosol inhaler. And that's about it. I continue to work out. I think it's really important to keep my lungs healthy and as healthy as possible. Exercise as much as I can. I am vigilant about what I consume. I don't engage in recreational drugs or anything that would, compromise my health.
Right.
So that's really about it. I've had a number of tests done, and they show some decline in function, but so that's it.
Yeah. So just as a reminder to our audience, we are taking questions. So if you're watching us live, just leave them in the comments section and we'll work in as many as we can. Dr. Sandrock, how typical is Marina's case? And what other kinds of symptoms are you seeing in long haul patients?
Yeah, it's both typical and atypical. I think her presentation, back in February, where, infection with SARS-CoV-2 or COVID was not on all of our radars, as she mentioned, we still were seeing a lot more influenza and non-influenza based viruses that were not, obviously SARS-CoV-2. So, most people back then when we tested them were negative. The first public case that sort of came out, which was one of the first ones reported here at Davis, was late in February. But we know now historically that, the disease was spreading, particularly in New York and throughout Europe. So at least, what should have been on our radar then or what wasn't on our radar should have been. And we certainly know that. So, her presentation back then was very typical: cough, shortness of breath, chest pain, extreme fatigue. And then as those symptoms progressed over the spring and summer, most notably chest pain and shortness of breath, that's probably the most common presentation. And what we're seeing is sort of a group of three types of patients. They may have all three ingredients, so to speak, or symptoms. They may only have one of them, but usually it's related to respiratory, so shortness of breath. And that will actually, what you'll notice is an accompanied rise in your heart rate, which, Dr. Oshana has, and then a drop in your oxygen saturation. Sometimes that can happen at sea level, like it is here in Sacramento. I've had a few patients, they make it as far as Auburn or, a little bit past that, so about 2,000 feet, and they're already at a low level. I suspect Dr. Oshana would actually, as she drives up to Truckee, can measure where she starts to drop off as she's resting, and, is actually at dangerously low levels by the time she hits about 6,000 or 7,000 feet. That's one subgroup. The other subgroup is one where, and you've noticed this in the literature a bit, and it's been reported in the lay press, where they have neurologic findings. So what we call strokes or brain fog or forgetfulness, that's another group. And then the third group is just extreme fatigue and exhaustion. So they may not have findings of respiratory or neurologic dysfunction, but extreme fatigue. We think the pathophysiology behind all of it is the same, but there's still a lot that we're learning. So, that's the tough part with patients who have persistent symptoms. And, it's not just everybody who gets extremely ill. We have patients who have minimal symptoms at first, and then 2 to 3 months later, they start to progress with shortness of breath and chest pain. We have some patients who are profoundly ill in the ICU with us. They recover, they have no persistent symptoms. So there's not really a rhyme or reason, and the initial severity of illness doesn't correlate with that persistence.
Wow, that's pretty amazing because, I just assumed that people who were long haulers were the ones who had really acute cases. But you're saying, you could have had it, not even known it, and now a couple months down the line, you're going to get these long hauler symptoms.
Yeah, no, exactly. And, the case with Dr. Oshana, she didn't have the classic nasal swab that we do where we look for the RNA for the virus. That's the main test we have to detect it when you have active infection. Then we look for antibodies, which is just sort of past infection. And, she was at a point where really there wasn't robust testing, so it wouldn't have been done then anyway. Her symptoms were so classic. And then when we looked and saw that, her test findings, most notably on pulmonary function tests, her ability to sort of process and take in oxygen had declined in a rapid way. Her classic findings of chest pain, inability to exercise, that's where it sort of came on our radar that, hey, she did have these symptoms, albeit very early on. But, back in February, we should probably just check. And of all my patients, actually, she's one of the few that's been positive. We get a whole handful of patients like this, and that's kind of the big first step in determining someone that has a post-COVID syndrome, or what we like to call a long hauler, is did they really even have the infection? Because so many other things can mimic it. So if they've had a prior nasal swab that was positive, sure, that's great. If not, we need to get antibodies. If both of those are negative, it probably actually isn't what we would call a post-COVID syndrome. It's probably something else. And then that way we can expand out our analysis and treatment.
And just to be clear, so, her initial tests in July were negative, the swab tests, because the virus at that point had already cleared her body, right?
Correct.
So the only way you knew that she had it was through the antibody test, which showed that her body responded to it. The immune system responded to it, right?
Correct.
So when you're in this long haul phase of it, you're not at risk of like nobody can get it from you at that point because your body has cleared the actual virus. You just have the symptoms that are lingering.
Yeah, so that's a great question. The general answer is yes. But at what point do you transition over from being, contagious or infectious to non-infectious as your symptoms persist? And that's always an open debate. The difficulty with the nasal swabs is they're just so sensitive. So you can detect just a small amount of virus, but at that point you may not be contagious. So that, by using a nasal swab, you may be, for lack of a better term, overcalling it. It's somewhere around 30 to 45 days where that ability to be infectious sort of wanes off. It can be as early as 2 weeks. But we do have patients where it's, 30, 45 days, even 60 days, that nasal swab is positive when we're detecting virus. And it's just hard to know, necessarily how infectious they are. We do use what's called cycle times in the PCR. So how many times we have to run a cycle to detect the virus. The more cycles we run, the less virus that's present. And somewhere around 30, 35 cycles, that's where you're probably not contagious anymore. Again, this is not FDA. It's not approved stuff. We just kind of look and make our best guesses. But, obviously patients who are symptomatic for 4 months, are they contagious for all months? 4 months? Probably not. When are they not contagious? Great question, because all the CDC guidance basically says when you can come out of your isolation is based on 3 days of no symptoms and at least 7 days from the first onset. But what do you do for people who have symptoms for weeks, right? And that's where you have to sort of make that call, which is hard.
Do you have any sense of what percentage of people who contract the virus end up, with this post-COVID long hauler situation?
Great question, and not at all. So we actually, this was just a meeting I came for before this, where we were trying to identify the number of our COVID patients who have persistent symptoms, and mining our electronic medical records to find that data. We have no idea. It's very difficult, and even just coding and tracking patients and knowing where they are and how many people are positive, we don't really have a good sense. Some of the literature is in some cohorts are reporting, upwards of 20% have persistent symptoms, but really we don't have a good sense yet. And that's going to be down the road. We'll get some more data as this progresses.
Right. We do have a viewer question. Valerie from Facebook is asking, how long are post-COVID-19 symptoms expected to last? I recovered from COVID-19 on September 2nd, but I am still experiencing extreme fatigue, chills, insomnia, blurry nighttime vision, heightened sensitivity to unhealthy air quality, etc.
Yeah. So, for Valerie, that's a great question. I actually, unfortunately, I don't know. And everybody's a little bit different. So, in the case with Dr. Oshana, here she is now. What is this now? About 9 months since February, right? My math is terrible when I'm.
No, it's exactly 9 months.
Yeah.
Right.
But, here we are 9 months from this and she still has symptoms. So, and we've noticed that symptom length is very variable, but, she's a nice example of someone early on in the pandemic contracts disease and is still symptomatic. So, unfortunately, I don't have an answer. And that's where our worry is as healthcare providers, is how much of this is permanent, how much of this is temporary. And unfortunately, we don't have an answer. That's why, when we hear people walk around and say, well, this is like the flu, it's not a big deal, I just got it and who cares? Well, there's this whole sort of post-COVID syndrome that can come up and persist for, we don't know how long. Right. And that's the concern we have. And there's just a lot we don't know about these viruses still.
Yeah, if I could just pick up on this point, unless you have another viewer question you'd like to get to, I'd like to add a cautionary note against complacency. So I was quite fortunate. I did not end up hospitalized. I was not on a ventilator. I'm up and walking. But for people who think that, as Dr. Sandrock said, this is just an iteration of the flu, you're going to get over it, you might not get over it. And we don't know, right? And the symptoms that I'm experiencing now, some of them were emergent in a sense. They weren't evident early on, but new symptoms cropped up. It wasn't until August that I developed chest pains and sort of stitches in my side walking around the block. So, that's one point I'd like to make. Another point has to do with testing. I've been tested several times. They've all been negative. The fact that I've been negative does not mean that I should stop wearing a mask, that I should cease social distancing and washing my hands. The negative test is only good at that time. It only indicates that you are not infected at that moment of time. Right. A couple hours later, who knows?
Right, exactly. Diana from Facebook is asking, what is known about the cause of the lasting neurological symptoms caused by COVID-19? Is there anything that can be done to lessen these symptoms?
Yeah, great. Also a great question. There's two theories behind it. And, now you're wading into the neurology world, which is one of my great weaknesses, but there's sort of two thoughts behind it. One is, and this is the same process that's happening with Dr. Oshana and happening with other patients, that you get what's called shunting. So, as this virus causes a big inflammatory response, one of the unique features with SARS-CoV-2 is it can cause inflammation in the blood vessels and you have clotting. So now these small, and they might be what we call microvascular at the capillary level, where you have this clotting and now blood can't flow through those capillaries. I think that's probably what's happening with Dr. Oshana. And, it's not flowing to areas of her lung and she can't exchange oxygen. That causes chest pain, shortness of breath, and fatigue. That's one common area. We think that may be happening on a neurologic scale as well. So obviously the brain, like the lung, is a very vascular organ. And there's tons of blood vessels, and at a small microvascular level, there's not quite the blood flow we need, and it may be shunted away from critical cells, and that's why you get a brain fog or thinking and so forth. The second mechanism is one of the common features we see with some people who get infected with SARS-CoV-2 is they lose a sense of smell and taste. And that's actually a direct death of those particular neurons. In this case, your olfactory cells in, your cribriform plate and up in your nose, they actually die. We don't have evidence that happens, necessarily within your brain, and brain cells are, dying. But there are two sort of processes that happen, and probably the two of those together will actually hinder things and lead to this sort of brain fog and fatigue, mental fatigue, loss of some certain sensation, intolerability to light in the environment, and migraines and so forth. So really probably those two processes.
Right. And just to be clear, SARS-CoV-2 is the official name of the COVID-19 virus. It's the same thing.
Yeah, correct. Yeah, we get a little anal about it. SARS-CoV-2 is the virus. If we do the test, it's not a COVID test. It's a test for SARS-CoV-2. Right. COVID's the actual disease. So yeah, we get a little technical. So sorry.
No, that's good. It's good to be accurate and precise. So I wonder, I feel like we might need to brace for a tidal wave of these post-COVID cases, because a lot of people may have had the virus and didn't know it, but still can suffer from this post-COVID syndrome.
Yeah, I think so. And that's the key, as we're trying to build our our post-COVID, syndrome clinic, we're realizing it's a very multidisciplinary event, and many other institutions that are doing the same with their patients are noticing the need for multiple specialists, right? So if, like Dr. Ashana, short of breath and fatigued, you can see a pulmonary doctor, but we also have patients who have cardiac abnormalities, who have neurologic abnormalities, who have psychiatric abnormalities, sleep disturbances. And, so really it's almost like you need a special clinic where you can come in and then get branched out to whatever your specialty might need, because, sleep abnormalities is very different than shortness of breath for symptom wise. The pathophysiology underlying it might be the same, but our treatment is going to be widely different across the board.
Right. What do we know so far about why some people experience these long-term symptoms as opposed to others who don't?
It's a great question. I don't know. And I think there's a lot of us, we don't know. There are, certain disease states we see that lead to severe illness early on. We've heard about diabetes, heart disease, high blood pressure, some underlying lung conditions. But, again, some of those patients, some patients will do fine. They're never admitted to the hospital. Then they have these long-term effects. What it appears to be is a combination probably of genetics and how you manage, sort of this blood clotting and shunting. And that's what we think. There is, why one person is totally asymptomatic and has no problems, the person next to them is sick. Great question. We have one of my colleagues here very early on, before we knew this virus was present. He actually, contracted COVID, and then unfortunately so did his wife, which is, common in unfortunately in our profession. His wife had a ton of symptoms. He had absolutely nothing, right? So, and they're both the same age. They live in the same household, and some of these differences we just can't fully account for yet. And there's a lot of unknown around, everything from health disparities and social disparities to underlying conditions that will lead to this, and we're still figuring it out.
My husband was completely asymptomatic. So
yeah.
Did he end up contracting it? He was asymptomatic, but he did have the virus.
I don't know if he had the virus because he wasn't tested for antibodies.
Okay.
It would be highly unusual if he had not contracted the virus, because, we lived together and he was with me for the entire duration of the illness.
Yeah, it's amazing.
Yeah, we do recommend, if one spouse gets sick and spreads it to the other spouse, that initial spouse who got sick has to do the dishes for a year.
There you go.
So, that's the payback that we've generally had. So
I'll let him know that.
And take that prescription home with her.
Joshua, who's watching on Facebook, is asking Dr. Sandrock, what can someone do to strengthen their immune system in order to protect against COVID? How long do you think it would take for a patient to fully recover from COVID after effects?
Yeah, so the strengthening the immune system, there's really not anything specific. So, obviously we have patients who have weakened immune systems because, for example, they're transplant or on immunosuppressive drugs. But for the average person whose underlying immune system is healthy, making sure obviously you sleep, you exercise, eat well. Just the basics behind that, I think, is all we can do. I don't have data on things such as zinc or vitamin C that's really going to have any provided benefit. What Dr. Oshana mentioned, really just abiding by all the protective measures is really the key. So this is one, not so much of mitigation where we, strengthen our immune system. It's one of prevention where, really wearing a mask, staying out of crowded places, not putting yourself at risk is really the key. Now, again, once you get the symptoms, how long they last, completely variable with everyone. So we just, again, had another one of my colleagues get sick, a fever for one day, totally fine and done, and then other people are sick for a while. And that variability, usually on average, when we look at the big cohorts, you're symptomatic for on average about 3 to 5 days. But again, there's outliers, obviously like Dr. Ashana and what we call the long haulers. And there's some people who are asymptomatic, but on average, it's about 3 to 5 days.
Right. Let's see. So Brandon, who's watching on YouTube, asks, any idea how long after the virus will the antibody test show antibodies? Would it still show up, say, 9 months later?
Yeah, so there was a lot of press around what we call waning antibodies. So on average, it takes about 2 weeks for the test to be positive. From symptom onset to roughly 2 weeks, you should start seeing antibodies turn up. Some people are as early as 7 days. Some people might be about 3 weeks, but on average, it's about 2 weeks. Now, you're usually positive for quite a while. There has been some discussion about waning antibodies and that people have a drop in their antibodies 6, 7 months after. But what we've really found is that most people are going to actually have detectable antibodies, 9 months out. And I suspect if we went to Dr. Oshana and tested as well, we'd still find, titers. Now, those titers vary. Some people are very high, some people are very low, but they're still detectable. So, in general, that's going to be starts at about 2 weeks. As far as we know, I think it's going to be quite a while. So, will it be 5 or 7 years? Probably not. But at least, for, 9 to 12 months, it's going to be pretty accurate, I think, in most patients.
And again, the detection of antibodies does not mean immunity. I mean, I don't think it means immunity. Does it, Dr. Sandrock?
Not necessarily, right? So we have seen people supposedly contract this twice. So there's two things, and that's the big key, right? So the big question is, are you totally immune and can you, have a party and walk around without your mask on and enjoy life? The answer is probably not, right? So if we've had one of my colleagues get COVID, do they then come back to work and not wear a mask? Absolutely not.
Right.
So they can come back. You can still contract disease. There are multiple strains of this virus, and we're thinking it's going to be not exactly, but similar to the flu, where smaller mutations might lead to lesser infections. But there have been a couple documented cases where people get a second infection, and that second infection is more severe than the first because they're sort of primed for that response. So we still recommend everybody who has positive antibodies act like they've never had it. And you're exactly right. That's perfect.
Jean from Facebook is asking, would the vaccine be helpful for long haulers? Can they be reinfected at some point, which you kind of answered, but would the vaccine be helpful in some way as far as maybe a treatment or a defense?
Yeah, other than, prevention, which is the goal, we don't really know of repeating vaccines in that subgroup. Mm-hmm. So the clinical trials, that data will come out, but the clinical trials from Moderna or, biotech or Pfizer, they did not include people in that subgroup. Obviously, there were people who were antibody negative, didn't have disease. That's part of the cohort. So this question with vaccines in patients who've otherwise been infected is going to be a question that's going to be outlying for a while. The thought is that we probably will still vaccinate those subgroups, but that's a testing that's going to have to happen down the road. And so there's still a lot of questions to be had with that.
Okay. Clay watching on Facebook is asking, is COVID toe caused by compromised circulation, and what does COVID affect, and why does COVID affect diabetics more? Why don't you tell us what COVID toe is first, and then?
Yeah, so COVID toe is it is a circulation issue. So as you get these blood clots, it happens in essentially the toes. It's defined, but what happens is your toes turn big, red, and purple. It is limited blood flow, mostly at the capillary level, not at a big blood vessel level. Because obviously, if you have a clot in a higher blood vessel, your whole leg turns red and then purple. These are just the toes turning purple, a lot like frostbite. And you have that limited blood flow, and that is also that what we call microvascular clotting, or clots forming in the capillaries. So that's really essentially what COVID toe is. And now, why diabetics are at risk for it is, again, a sort of an open question. They're probably more at risk both for infection, because that comes through what we call the ACE2 receptor, and they have high blood pressure and dysregulation with that receptor that sort of puts them at risk. And then just like with influenza, the complications of inflammation and blood vessel regulation are altered in diabetics. So they're more prone to clotting and some of the adverse vascular events associated with that because of their high sugars and the complications thereof.
Let's see. Emily watching on Facebook she says, thank you for sharing your story with us, Dr. Oshana. Question, are the persistent respiratory issues / problems mean the lungs are permanently damaged? Do we know whether there's any permanent damage here in general?
I think that's a question that Dr. Sandrock should answer. So my understanding is no, we don't know. And I haven't seen any evidence that there is improvement, but it's early days. So,
yeah. I actually think there's two sort of lung processes that happen. The one that Dr. Oshana didn't have, thankfully, is you get an acute infection. It affects your lungs. That's what we call ARDS, acute respiratory distress syndrome. It's what we call fibroproliferative. So there's extensive scarring. That's generally what kills most people in that 2 to 3 week period after they have infection. That usually starts roughly around day 8 of infection or so. So that's why we always say, hey, you have that fever early on, and then you feel a little better, and then we're always worried by between days 7 and 10 what's going to happen with our patients. That's sort of the fibroproliferative stage. that leads to lots of scarring in the lungs. We are seeing that patients with this are recovering slowly, but they still have deficits. When we look at fibroproliferative disease in influenza and others, some patients recover near fully, some unfortunately will have persistence. Then there's what Dr. Oshana had, which she didn't have that, but she obviously has other parts affecting her lung, probably what we would call microvascular disease, even though all of our tests didn't show that. She probably has it at a small level. That is causing some deficit in the ability of oxygen to cross, over through the air sacs into the bloodstream. And it's a great question whether that's permanent. I think it probably won't be. And that's my bias. But again, this far out, we don't have evidence. We have some evidence of reversal in some people. We have persistence in others. So, but I think in most people, there'll be some resolution. But the question is how long? And, is there any treatments that will speed it up, which is we don't really have great options at the moment.
Right. So that was what I was going to ask you that next. So what can you do to help people with these long haul symptoms?
Yeah. Great question, right? So we don't, obviously specific things such as sleep disorders, if they've had a stroke or big clots, we thin out the blood, but usually we've detected a large clot or we measure blood inflammation. And if the inflammation is at a certain level, that will actually, prompt us to treat them with blood thinners. And we've noticed in some of our patients who have low oxygen levels, they might walk 10 feet, their heart rate goes up to 130, that as we thin out their blood, those get better. But they have markers of moderately severe inflammation prior to treatment. We have patients who have no markers of inflammation, but they're like Dr. Oshana, where they're still short of breath and their oxygen level's low. So then do you treat them with anticoagulation and put them at risk of the complications of anticoagulation? Or do you just wait and see because they're able to sort of do okay, without much oxygen support and they can limit their activity? And that's the $1 million question. So on a lot of our listservs with a lot of the experts around the country that we're talking to, there's a lot of divergence on how to manage this with no consensus. So there's really, at this moment, we don't have a great opportunity or option for treatment other than if we know you have a lot of inflammation in the clot, we're going to, thin out your blood or put you on an aspirin if you've had a stroke and so forth.
But it still goes back to Professor Shauna's point of don't be complacent,
Right.
kind of like, because the worse it gets, the harder it is to come back from it.
Correct.
Right?
Yeah, she said it perfectly.
Good
Yep.
point.
Yeah. Is this similar to any other disease, like maybe chronic fatigue syndrome or anything like that?
That's a great question. The chronic fatigue, which, has multiple different newer names now, but there is a component of excessive fatigue with this virus that may overlap. But really the findings of, sort of the brain fog, the, discrete pulmonary findings and so forth are a little bit different. So, and that's a great question, right? Because you can come in and say, well, I think I had COVID, right? We test you, your antibodies are negative, but you think you had COVID. Then we put you through a series of tests and you should have some deficit, right? So if we do pulmonary function tests, you have a lower ability to manage your oxygen, like Dr. Oshana mentioned with herself earlier. If that's negative, we can look at how the blood flows through your lungs and how, if there's any issues there. We can put you on a bicycle and do what's called a CPET or cardiopulmonary exercise test to see if there's any deficits in your lung and heart. Very often, those tests are all normal in someone with chronic fatigue, and this is more of a chronic fatigue syndrome, and they don't have discrete deficits in pulmonary or cardiac function. With post-COVID, we actually find discrete deficits, and I think that's really the difference that we notice. But there probably is a component of post-COVID that's going to be like chronic fatigue, I think, as well.
Mm-hmm.
Sorry, long answers. I apologize.
No, that's good. No, we like that. Let's see. Joan, who's watching on YouTube, asks, is the loss of taste and smell that accompanies the virus infection permanent for long haulers? Do we know that yet?
Some people recover and recover slowly. We think it's not going to be permanent, but there are people 6-7 months out and they still can't smell. So, you can imagine if you've had a nerve injury, on average, it takes 6 to 12 months to regrow those nerve connections. And that's what actually has to happen. There is a possibility that, your sense of taste and smell comes back, but it's going to be altered, as the wires get crossed, for lack of a better term, or you might actually have some recovery of that fully. And that part is hard. I will say in the healthcare world, it's made us completely nuts, but we work so much, we're doing night shifts. So to have fatigue, body aches, lethargy, that's just part of our job.
Right.
And we all joke about it because we have our masks on and we might, have a piece of gum or we smell our own bad breath. And we're like, well, I can smell my own bad breath. At least I don't have COVID right now. We can keep working. Right. So we joke about it, but that is one of the hallmarks. And that loss of sense of smell is a very common reason people get tested. And if you lose your sense of taste and smell, definitely get tested, because that is a classic hallmark unique to this virus.
Zenya is asking, for those of us seeing GPs who have little experience with long haul, what recommendations do you have for self-care to try and get better, or maybe things to watch for, et cetera?
That's a good question. I would say two things. One is, I think the story Dr. Oshana tells is really a good classic story. So as you resume your daily activities of life, whether it's riding your bike, exercising, just walking, doing your job, if you notice those deficits that may be associated with, your COVID infection, just like Dr. Oshana saw, I think that's a clue to be seen. If your GP is not familiar with it, I would refer, that's why we're here. And that's why specialists are here. You might not be part of the UC Davis health system. You might be part of another one, whether it's Kaiser, Sutter, or another part of the country. But that's a reason to be seen by a specialist, whether it's pulmonary or ID or cardiology, to really look and see what those are, because again, the treatments are not amazing at this point, but there are small treatments we can do, particularly things like anticoagulation, aspirin, certain exercise and rehab, optimizing sleep. We certainly don't want any brain dysfunction at all. So getting those checked out, I think, is important. That's a big reason for a referral away from the GP if they don't feel comfortable with that, which is totally fine. We're struggling with it and we're the specialists. So I don't expect.
Are there resources for general practitioners to find the latest or, the best practices on this front?
Yeah, there are for COVID, but this post-COVID is sort of evolving. Right. There are, some resources, whether it's, using common places like Medscape or UpToDate, which many of us use, or using some of the societal information, whether it's, the IDSA, Infectious Disease Society of America, Society for Critical Care Medicine. Each society has some of their data. And I think, the general practice docs have their own as well. But it's, this data evolves. By the time you write an article, 20 new things have come out. So that's the part, is that we almost function on the existence of rumors. Hey, I heard some guy did this in New York, and then everybody gets all excited. Right. That's dangerous, but it's also at the same time, that's kind of how things emerge. So that's why seeking second opinions, going to specialists, people who see this a lot, sometimes are key. But the key for a patient is if, just like Dr. Oshana, they have ongoing symptoms, that's the trigger to see someone. If you had the infection, but you feel great, I probably wouldn't push for that per se yet, unless you have some persistent symptoms.
Right. Just in general, be attentive to your well-being, to your health, and notice things that are out of sync with how you tend to feel. And don't interpret every dry throat as COVID. I mean, I can understand why people are inclined to be more panicky because this is a really scary disease. But if something like tightness in your chest occurs and you're not prone to anxiety attacks and it persists, go see someone.
Right. Yeah. And I think that's key. We're seeing sort of two forms of denial, I think, with COVID, which is hard. One is the first one, which is, not unusual for any disease, is people will just say, well, I'm fine. I don't have any symptoms. And this was early on where, the first asymptomatic cohort came. When you actually went back and questioned them, a lot of them did have symptoms. It's mild, but they had symptoms. So, I saw a patient the other day that came in for exactly this post-COVID process. And they said, well, I got tested and I was positive. Well, why did you get tested? Oh, the doctor made me. Well, why did the doctor make you? I don't know. They just made me. And after questioning, you find out, well, they lost their taste, their taste and smell. They were tired. They had night sweats and they had a small cough, and you think it, just like Dr. Shana mentions, how could you not notice that? And people sometimes really just don't, Right. And then the other is, obviously there's been a lot of politicalization of COVID. So there is a big component of our society that doesn't believe it exists. And it's very disheartening to me, but I'll have many of my patients, they're like, I don't have that disease because it doesn't exist. And it's like, well, it actually does exist and you do have it. Right. And we know it exists. And this is not us trying to be political, but unfortunately it became, politics. And that makes our job a little bit harder when people don't think they actually have it. It's been tough some days.
Right. Ruth, who's watching on Facebook, asks, being a long hauler, what exercise is good for me, as I used to run 5 miles several days a week?
Yeah. I'll have Dr. Oshana mention something in a second about hers, but we used to think our rule was if you had an infection and you wanted to exercise, go ahead, exercise. It's good to exercise hard. There's a little data coming out of Britain now that and it was a New York Times article that which was a offshoot of Lancet, that sort of suggests maybe we shouldn't push ourselves that hard after COVID. Now, I think exercising is important, but I think exercising while you have chest pain, while you're short of breath, while you're uncomfortable is not smart. So I would think, as a long hauler, getting out, walking, staying active, absolutely key. So, don't be bedbound and on the couch as long as you're feeling okay. I mean, if you're getting up and you can't walk to the kitchen, you have chest pain, you need to be seen. But if you can do some basic stuff and not push yourself to the point where your oxygen levels are too low, I think that's the limit. But I'll let Dr. Oshana comment because she personally experienced it. So
no, I think that's absolutely right. I think that one thing that's difficult is that we have to learn to be, to dial back our expectations and recognize and accept that we might not be able to run that 5 miles, and I might not be able to achieve the same working heart rate that I did when I was, doing my cardio exercise. I just can't do that anymore. And it's frustrating, but it's also humbling. Maybe take it as a lesson in humility. Do what you can, right? But don't push yourself, because as Dr. Sandrock points out, there is evidence emerging, scientific evidence, not some, bonkers wackadoodle claiming he knows better than scientific experts, that the pushing yourself to the extreme until you hurt, right? This idea that you have to work until you hurt can cause heart distress. You don't want to end up dropping dead of a heart attack or experiencing cardiac arrest. So be humble about what you can manage.
Right. Listen to your body, basically. And, you don't want to put yourself in further peril, and hope that maybe this limitation is not permanent, because, by listening to your body, you're actually helping yourself to heal.
Your body and not your ego.
Right.
Yes.
But don't go overboard.
Yeah.
Yeah. I guess to wrap up, Dr. Sandrock, how do you think in general the introduction of vaccines in the next few months is going to affect the pandemic?
Oh boy. Yeah, that's a hard question. My hope is that and again, it takes a little while for immunity to build up. So this is not something that's going to open doors, by December. I think it's going to first start out by helping us in the healthcare world. So you probably saw the CDC recommendations, multiple other groups, whether it's, us across all of the UC's, Office of the President, the CDPH recommendation here in California is really to focus on long-term care facilities and obviously healthcare workers, so we can provide care. But I think as immunity builds up, we've heard this term a lot, a ton of time of herd immunity, right? So we're going to, developing herd immunity the natural way where everyone gets affected. We're kind of going through that right now, and it's obviously not working particularly well for us on many fronts. But the vaccine will allow us to speed up that herd immunity. So if we look ahead to the summertime where people can travel and have vacation and, we open up our borders and economy more, or next fall where kids and universities are going to be able to go back to school, I think that's going to be more secure and more rapidly available. And then obviously the biggest thing is we reduce cases and we reduce deaths. And that's really where our ultimate goal is with vaccination.
And we are all waiting for that day so gratefully, and hoping it comes sooner rather than later. This has really been so great. Thank you so much for coming on today and sharing your work and experiences with us.
Thank you for having us.
Yeah, no, thanks. I appreciate it.
Yeah, I do too.
Dr. Christian Sandrock is a professor of pulmonary and critical care medicine at UC Davis Health. He's part of the team that recently launched a post-COVID-19 clinic to help patients dealing with long-term health issues associated with the virus. And Marina Oshana is a professor emerita with the UC Davis Department of Philosophy and a patient of the UC Davis Health Pulmonary Medicine Clinic. She's been dealing with COVID-19 symptoms since February. We will see you in the new year. Until next time, I'm Satirius Johnson, and this is UC Davis Live COVID-19.